now we're moving on to thoracic spine. There's generally just an AP and a lateral and then a swimmer's view, but we're also going to demonstrate AP obliques. I don't know of any clinical site that actually includes AP obliques as part of their protocol. However, it's potential on the ARRT, so we're going to teach it. All right, so your collimation for the thoracic spine is the same as it was for the L spine. It's 17 inches by 7 inches. Pretty much the spine just goes right down the center, so you can place your marker anywhere along the edge of the outside part of the field of view. Align the detent. Okay. I'm going to make sure that my patient is centered down the mid-sagittal plane of the table, so I'm going to turn him just a little bit. You okay?
Shouldn't lick the cat.
Okay. I'm centering midway between xiphoid tip and a manubrial notch. You can palpate a patient's manubrium. You can ask them to point to the bottom of their sternum, and your central ray is entering halfway between those 2 points. So that's roughly T7, halfway between manubrial notch and xiphoid tip. Knees are bent again. Not only does it reduce the lordotic curve of the lumbar spine, it also relaxes the kyphotic curve of the thoracic spine. So we're going to have the patient bend their knees. They can be shielded for this. And for the AP thoracic, you're going to have the patient take in a breath, blow it all the way out, blow all your air out, stop breathing, expose. You can breathe. What that does is raises the diaphragm, gets rid of a lot of the black looking part of the lungs that on inhalation they would look black. You see the lung markings, and it just makes a more even density from top to bottom. So that is our AP thoracic spine centered at the level of T7, 7 by 17 inch collimation. I'm going to go ahead and demonstrate the lateral thoracic spine, and then I'll demonstrate one of the AP obliques. Okay, for this next projection, what I first want you to do is slide toward me a little bit on your back, and now roll all the way onto your left side. Bring your shoulders back toward me. There we go. Now that he's on his side, I could give him a pillow back, because now his shoulder is, creating some distance between him, and if I didn't give him a pillow, his head would be slanted. He's locked his arms in front because he remembered what he had to do from the L spine, so good patient. Okay, I'm going to have shoulders and hips right on top of each other in the same coronal plane. And then my centering, again, it's going to be at the level of T7. So for this one, I could palpate the bottom of his scapula, and I could center at T7 that way, or you can gauge by feeling breastbone, xiphoid tip. But in this position, can you bring your arm behind you? In this position, I'm just going to feel for the bottom of his scapula, and that's where I'm going to center, because I know that that's at the level of T7. So we're centered. Now, your book talks about centering along the posterior half of the thorax. So if you're on mid-coronal plane, which you find by making sure that shoulders and hips are in the same plane, I'm looking at the mastoid tip. Right now I'm on his mid-coronal plane. I want to center halfway between the mid-coronal plane and the posterior surface of his body. All right, so halfway between mid-coronal and the posterior half. So that's going to be about right here. I'm going to be on this coronal plane, not the mid-coronal plane, but one that is posterior to that. Okay, I'm at the level of T7. I'm going to, again, because we're going through a really thick body part, I'm going to place a strip of lead behind the patient to absorb scatter, and I'm all set to go. So this particular picture here is going to take about 3 to 4 seconds, and I just want you to breathe normally throughout the entire picture. We're going to use a breathing technique on this to blur the ribs and allow us to see just the vertebral bodies without that obvious overlap of the ribs. So breathing technique for the lateral thoracic. All right, now if we were going to do obliques of the T-spine, our AP obliques are done by starting in the lateral position and having your patient roll back only about 20 degrees. It's a very slight roll. It's just off of lateral, about 20 degrees, and I'm going to try to center over the spine. Make sure that his hands aren't in the way, and if his head is aligned with his body, I can gauge where his spine is, and I'm just going to be centered over his spine. So there should be a little bit of light left over on the edge here. You can see light. Why am I at 47? That's why it looked weird. Okay, I should be down at 40 for this. Okay. So we're centered on the spine. I'm going to bring him just a little bit more anterior. That is our oblique, AP oblique. So starting from lateral, roll the patient back 20 degrees. If he was prone, you would be rolling 20 degrees forward from lateral. Now his arm would be in the way, so I would need to bring his left arm behind him. If I was going to do PA thoracic obliques, I would probably put him in against the upright bucky. In our positioning lab and for our simulated evaluation, we're going to be doing AP obliques of the thoracic spine. I know he doesn't look very AP, but it is because he is rolled slightly off of lateral. It's entering the anterior aspect of his body and exiting the posterior. So it's still considered an AP oblique, even though he's only rolled 20 degrees. Okay, one more position is the lateral recumbent version of the swimmer's view. I demonstrated the upright swimmers, which is called a twinning method, and the lateral recumbent version of the swimmers is called the Paulo method. So for this, instead of a pillow, I would have the patient just bring their dependent arm, the one that they're laying on, all the way up under their head. And I would have them, with their opposite arm, try and reach down and just grab the back of their thigh. That depresses this shoulder and raises this shoulder, and then make sure that their head is rotated completely laterally. I would have a 10 by 12 cassette, but in the interest of time here, I'm just going to collimate to a 10 by 12 because if you're on direct capture, you're not changing out cassettes anyway. You're just adjusting your field of view. So I'm going to be down roughly to a 10 by 12. He is on his left side, so I'm going to use a left marker. And I'm going to be centering at the junction of C7T1. So again, with this shoulder depressed, I'm pretty much going to just be skimming the top of his shoulder. That's where my central ray is going to enter. raise your chin just a little bit. I'm on the mid-coronal plane, which is where his spine is, and I'm centered. It's passing through at the level of C7T1. You can feel back here the vertebral prominence, so I know I'm just below C7 and I'm entering right between C7T1. A swimmer's view is always part of a thoracic spine series because on the lateral thoracic, you're never going to see C7 or C7T1. On a lateral cervical spine, you only include a swimmer's view if their shoulders are too broad or you didn't see the C7T1 junction. And on some people you can. Depends on how much their shoulders slope. So it's as needed on a cervical and always on a thoracic when you do a swimmer's view.